So the clinical scenario was also pointing towards an SVT, and we confirmed the diagnosis of SVT on ECG as well. So who will tell me the step was management of SVT?
First, Valsalva maneuver, carotid
Yes.
sinus massage.
Yes.
Then in response, then adenosine 6-12-12. If no asthmatic, if asthmatic, we cannot give adenosine.
So in asthmatic, which drug will you use?
Amiodarone? No.
Myodrone is an antiarrhythmic drug.
Verapamil.
Verapamil, that's right. The person is presented to you with palpitation, and you want to control his heart rate, and he is asthmatic. So after carotid massage and Valsalva maneuver, the drug that is the drug of choice for the management of SVT, if the patient does not have asthma, that is adenosine. 6 mg, 12 mg, and then again 12 mg. And if there is no response with adenosine, then what will we do?
Calcium channel blocker.
We have already tried the pharmacological intervention.
Then DC cardioversion.
Yes,
DC cardio.
DC cardioversion. The last option that we have is to DC cardiovert the patient.
So why we are not using amidrone here?
Amidrone is an antiarrhythmic drug.
And adenosine will control the heart rate.
Yes, adenosine is the drug of choice in the management of SVT.
So what if the patient is asthmatic? Then what will we
Calcium
use
channel
then?
blocker. Then we will use calcium channel blocker.
The cardio selective.
Yes, the cardio-selective one.
Okay.
If you are treating the problems in the heart, then you will select a cardio-selective calcium channel blocker such as verapamil and diltiazem. A myodrone is used only in the management of atrial fibrillation. If we are looking for a rhythm control strategy, now can someone tell me which is the other indication or arrhythmia in which we can use the myodrone?
Atrial fibrillation.
Atrial fibrillation, other than atrial fibrillation, which is the second one? February Plabbers, I expect you to answer this one. Okay, how we are going to manage ventricular tachycardia in a hemodynamically stable patient? What is the management of ventricular tachycardia in a hemodynamically stable patient? Okay, what is the drug that is used in the management of torsade de pointes?
Nexal.
Yes,
sulfate.
magnesium. Yes, magnesium sulfate. That's right. So the management of ventricular tachycardia in a hemodynamically stable patient is imidodrone. So imidodrone is used in the management of ventricular tachycardia if the patient is hemodynamically stable,
Atrial fibrillation.
and it is also used in the management of atrial fibrillation when we are looking for a rhythm control. So don't forget these two in which imidodrone can be used.
So repeat this again. Atrial fibrillation and
ventricular tachycardia. So how will we manage a patient with ventricular tachycardia but hemodynamically unstable?
DC cardioversion.
DC cardioversion. Any arrhythmia, remember the law, any arrhythmia in a hemodynamically unstable patient, the management will always be DC cardioversion. Whether it's ventricular tachycardia, whether it's supraventricular tachycardia, whether it's atrial fibrillation, all of them, if the patient is hemodynamically unstable, then we'll do DC cardioversion. All the arrhythmias in hemodynamically unstable patient, the management will be DC cardioversion. So, which question, any more question you want me to discuss, or should we start today's topic?
Sir, next question, sir. I am sending it in the
Sorry,
group.
1 second. Can we know the answer of this question? The one with the ECG.
So what will be the answer of this one? The
So
diagnosis
that
is
adenosine.
SVT.
Yeah.
Yes, the answer will be adenosine.
Okay. Right. So there was options of.
Option,
So-
let me show you the options. Just give me a minute. I'll show you the option as well. So the options were intravenous verapamil, oral bisoprolol, intravenous adenosine, oral digoxin, intravenous amiodarone. So the answer will be intravenous adenosine.
Right.
Intravenous verapamil will be used in SVT. What are the indication of intravenous verapamil in SVT?
When the patient has got asthma.
Yes. And remember that verapamil is contraindicated in ventricular tachycardia. In ventricular tachycardia, we use amiodarone.
Right.
So let's discuss the next MCQ. A 63-year-old woman.
Sir, I have
Just
shared
give me a
on.
minute. Share it here. So is this the MCQ you are talking about, Dr. Sambal?
Yes, sir.
Can you please read it?
Yes, sir. A 63-year-old woman is reviewed in the heart failure clinic. She remains breathless on minimal exertion. Despite being treated with furosemide, bisoprolol, enalapril, and spironolactone, an examination, the chest is clear to auscultation and minimal ankle edema was noted. Recent results are as follows: ECG sinus rhythm with a heart rate of 85 beats per minute, chest X-ray, cardiomegaly clear, lung fields, echo ejection fraction 32%. Her records mention that a combination of isosorbide dinitrate with hydralazine has been tried recently, but was stopped due to side effects. What is the most appropriate medication to add to her current medication?
So, what is the diagnosis here?
Heart failure.
Yes, the diagnosis here is heart failure. So now tell me, what are the drugs that are used in the management of heart failure? The drugs are given in the scenario already. Loop
Um,
diuretics, yes,
yes, loop diuretics, beta blockers, calcium channel
yes.
blockers, and potassium sparing, or digoxin being the last one.
Now, yes, you have told me the drugs, but now remember these drug in this sequence.
Yeah. So you start with the loop
Uh,
diuretics.
Loop diuretics is for if the patient is in a fluid overload,
Yeah, yeah, furosemide.
as there is ankle edema
Yeah.
and mild crackles in the lungs.
Mm-hmm.
So loop diuretic is for that purpose. Now the first line drug,
Would be either beta blocker or calcium
beta
channel
blocker,
blocker.
beta blocker,
Mm-hmm.
and calcium channel blockers are not used in the management of heart failure
Oh, okay. I thought
because
you
they
added.
no, that was in the management of angina.
Mm.
Can you please tell in the sequence in the heart failure which was
The reason calcium channel blockers are not used in the heart failure is that the person is already in the heart failure, and if we give a calcium channel blocker, then the calcium channel blocker, the cardioselective calcium channel blocker, they are reduce the contractility of the heart further, and the person is already in the heart failure, so it's not going to help. It will worsen the symptoms of a heart failure. So beta blocker and calcium channel blocker, they can be used in the management of angina, but the management of heart failure is different.
Yeah, so
So the
for
first
heart
line drug is
ACE
heart failure.
inhibitor
First
or
line
beta
is
blocker.
beta blocker. Yes, that's right. Beta blocker or ACE inhibitor in the first step, either one of them. In the second step, if in the first step if we started an ACE inhibitor such as enalapril, then in the second step we will give a beta blocker, and vice versa. Is that right?
Yes, correct.
Sir, please repeat it again one more time.
First time is beta blocker or an ACE inhibitor. Remember that ACE inhibitors such as enalapril, captopril, and ARBs such as valsartan, telmisartan, losartan, they are the same drugs. So either we can give an ACE inhibitor or we can give an ARBs. If a person, the side effect of ACE inhibitor is dry cough. So if person cannot tolerate or if a person dry cough with ACE inhibitors, then we can change this drug to ARBs. They are the same drugs. Their mechanism of action is different, but the effect they produce is same because basically both of them blocks the action of angiotensin enzyme or angiotensin 2. So beta blocker, ACE inhibitor. First drug is either a beta blocker or an ACE inhibitor. Second drug is, if in the first step we give beta blocker, then in the second we will give an ACE inhibitor, and vice versa. The third drug is another. Basically, in heart failure, you can say that we are targeting the renin angiotensin aldosterone system. So first we try to block it with an ACE inhibitor. Then if there is no effect with it, then the third drug that we add is an aldosterone antagonist, that is spironolactone. Now, the other drugs that can be tried in heart failure is that in heart failure, the basic abnormality is that the heart is not able to pump properly. With bisoprolol, in heart failure, if but the person goes into the heart failure, two systems are activated. One is sympathetic system, and the other one is renin angiotensin aldosterone system, and they cause more harm than good. So with bisoprolol, we block the sympathetic system. With enalapril and spironolactone, we block the renin angiotensin aldosterone system. Now, what else we can do to improve the symptoms of heart failure or to improve the cardiac output or ejection fraction? Ejection fraction or cardiac output can be improved if we decrease the afterload. And what is afterload? Afterload is basically peripheral arterial resistance or resistance in the aorta or in the blood vessels against which the heart needs to contract to pump the blood. So if after blocking sympathetic system and renin angiotensin aldosterone system, if the person is still having symptoms, then we can give some drugs which will cause vasodilation. So it will decrease afterload. And what are those drugs? They are isosorbate dinitrate and hydralazine. Hydralazine and isosorbate dinitrate, both of them releases nitrous oxide and they causes vasodilation. So basically they reduce afterload. So these are the drugs which can be used in the heart failure. So what is the strategy? Block the sympathetic system through a beta blocker. The effect of sympathetic system, such as increased heart rate, can be blocked by a beta blocker, bisoprolol, and will block renin angiotensin aldosterone system. Angiotensin is blocked through enalapril or losartan or valsartan, either one of them. And aldosterone is blocked through spironolactone. So we will add stepwise in these drugs. If still there is no improvement, then we can add isosorbate dinitrate and hydralazine. So in this scenario, the person has tried all the drugs. He is being treated with furosemide, bisoprolol, enalapril, and spironolactone, and a combination of isosorbate dinitrate and hydralazine has been tried also. But they needed to be stopped due to side effects. So what is the most appropriate medication to add to her current medication? So did we leave any drug that can be used in the heart failure? So now let me show you the
Sir, only digoxin was left, and that is
yes, digoxin was left, and that is the answer. You are right. Let me show you the option so that it can be clear to all of you.
So, what is the role of digoxin?
Digoxin is a positive inotropic drug. It increases the contractile force of the heart. So it can improve ejection fraction, but it is used in the last because the therapeutic window of digoxin is very narrow. A person can develop serious arrhythmias because the therapeutic dose of or the therapeutic window of digoxin is very narrow. That's why it is not recommended to use usually in the heart failure. But if a person is not left with any other drug and the only option that is left is digoxin, then it can be prescribed.
Okay, sir.
So losartan was not an option because he's already taking ACE inhibitor. So either one of them can be used. Diltiazem, calcium channel blocker, is not used in the management of heart failure because calcium channel blocker decrease the contractility of the heart. So they will worsen the heart failure symptoms. Isosorbide mononitrate is already tried, and busantin is not a drug that is used in the heart failure. So the only option here was digoxin. So the management of heart failure, clear to everyone?
Yes, sir.
One question is like if the patient is not taking hydralazine or isosorbide mononitrate, so could we add straight away digoxin instead of that?
No, we cannot add digoxin instead of that. We need to try all the drugs before trying digoxin. The reason I have already told you that the therapeutic window of digoxin is very narrow. Or we have another indication. If the person is having atrial fibrillation, then you can use digoxin as well.
Right.
Doctor, I have one question. What is the
Yes.
role of ivabradine in heart failure management?
Ivabradine in heart failure.
Mm.
Ivabradine is a drug. It is a new drug. Ivabradine basically is not used in the heart failure. It is used in the management of angina.
Okay.
But ivabradine can also slows down the heart rate. So I don't know if the recent guidelines include uh, this drug in the management of heart failure. It acts on in the fast acting sodium channels that are present in the cardiac membranes, and they blocks the fast acting sodium channels or the current. So they decreases the heart rate.
Mhm. Okay, doctor. Thank you.
But in the guidelines, in the NICE guidelines, it is not included in the management of heart rate or heart failure. But it can be used in the management of stable angina. You joined the session a little late, and we discussed the management of stable angina before you joined.
Thank you very much.
So, did you, Dr. Mliha, did you read somewhere that it's used in the management of heart failure, the ivabradine?
No, it came, I think, from European Society guideline. Just I was asking, I was wondering.
Okay. Any more questions?
Yes, sir. Last question I'm sharing on the group.
So, let me show you the management of heart failure in Plab 1 case.
Sir, I have shared the question.
Okay, just so can you see this management of congestive heart failure? So see,
Yes, sir.
Yes.
stepwise management is given in the Plab 1 case. That's why if you do Plab 1 case thoroughly, if you revise it again and again, then there are very less chances that you will miss any question in the Plab 1 exam. But what you need to focus on is to do them thoroughly and revise them at least 2 to 3 times. See, ACE inhibitors, beta blockers. In third step, aldosterone antagonist, and in fourth and fifth step, hydralazine with nitrates. This MCQ was a ditto copy of this Plab 1 key. So all the drugs were tried, and still the patient symptoms does not improve. Then we added digoxin. Okay, let's see the other question. Yes, this question, a 25-year-old female. Can someone read this question? Let me.
So, 25 years
Yes.
old female is found to have left hemiparesis following a deep vein thrombosis. An ECG shows right bundle branch block with right axis deviation. What is the most likely diagnosis?
So the scenario is giving that a 5-year-old female is found to have left hemiparesis following a deep venous thrombosis. So can someone tell me where where does a venous thrombus travel to?
The lungs.
Right side?
Yes, to the right side of the heart and to the lungs. So deep venous thrombosis is usually associated with pulmonary embolism. But this patient is having a stroke with a history of DVT. So someone with a history of DVT and who develops a stroke, what is this phenomena called? This phenomena is called as paradoxical embolism. What is paradoxical embolism? That a venous thrombus has traveled to the systemic circulation or to the arteries, such as to carotid artery, and which has resulted in the development of stroke. So this phenomena is called venous paradoxical thromboembolism. So which heart condition is associated with paradoxical thromboembolism? Can anyone remember that? It's also given in the Plab 1 keys. Again, I'll emphasize for the February Plabber that focus on revising Plab 1 keys again and again. It is more important to revise Plab 1 keys even if you do not do any mock exam, but please revise Plab 1 keys thoroughly, especially for the bigger chapters such as cardiology and neurology. Let me show you in Plab 1 keys the answer to this question as well. So patent foramen ovale has long been studied because of its role in paradoxical embolism, an embolism that travel from the venous side to the arterial side. This may lead to a stroke or transient ischemic attack. Can everyone see these lines?
Yes.
These lines are taken from the Plab 1 keys. It is written clearly that paradoxical embolism is associated with patent foramen ovale. Patent foraminal veil is also known as atrial septal defect. So atrial septal defect has a complication, and that is paradoxical embolism. What is paradoxical embolism? An embolism that travels from the venous side to the arterial side. And what will happen if the embolus travel from the venous to arterial side? This may lead to development of a stroke or transient ischemic attack. So is it clear, everyone?
Yes, sir.
So now let's answer this question and tell me the answer of this one. So what is the answer?
Ostium
Atrial
secundum.
septal defect. Second one,
Osseous
osteal
scandum with atrial septal defect. Any more questions?
Yes, sir. The last one
Which one?
is the ECG with ECG, the 71-year-old I shared just now.
Yes, this was also an important question related to ECG. Just give me a minute so that I can share it on the Zoom. So a 71-year-old male presents to emergency department complaining of dizziness, and ECG is taken on arrival, and that shows the following. What is the most likely, the single most likely diagnosis? In the November Plab 1 exam, there were 2 questions in which ECG was given. So that's why I included some ECG questions, some commonly asked ECG question in the mock exam. This is one of them. So you can see that, can anyone tell me what is the ventricular rate in this and what is the atrial rate in this ECG? Ventricular rate and atrial rate. Anyone? This ECG looks like an ECG of heart block because the heart rate is very slow. You can see that there are 1, 2, 3, 4, 5, 6, 7 and a half large boxes between 2 R waves. So 300 divided by 7 is somewhere between 28 to 30. So it's
No,
a heart block.
it's 40, around 40 there.
Yes, it's around 40. So it's a heart block. Now we'll decide, is it a first degree heart block? Is it a second degree heart block type 1 or it is a second degree type 2? It's not ventricular fibrillation, so we have ruled out this option because in ventricular fibrillation there is tachycardia or blood complex tachycardia. So we are left with the all the other remaining options. It can't be a first degree heart block because in the first degree heart block there are no decreased heart rate to this extent of 40. So we are left with the third degree heart block and a second degree type 1 and a second degree type 2. It cannot be a second degree type 1. In second degree type 1, a missed beat is preceded by a progressive increasing of PR interval. Now the only thing that look at in lead 2 that this is QRS complex, this is T wave, and immediately after T wave there is P wave. So this point is a very diagnostic of third degree heart block. This point that the T wave is mounting on the E wave is very diagnostic of a third degree heart block, because it signifies that there is no relation between the QRS complexes and P wave. Normally there should be a specific interval after which a P wave should originate or should arise. But in this ECG you can see here and here as well that there is T wave, but the P wave is merged with the T wave. Similarly, you can see here that the T wave and the P wave, both of them are just immediately close to each other.
So doesn't it look like a first degree heart block as well? Because
Yes,
I
sir.
feel
Yes, sir. The same.
yeah,
Let
yeah,
me
I
show
feel
you
from
the
first degree, yeah.
in first degree heart block, the P wave will come on their time and not just after the T wave. See in this diagram, this is a first degree heart block. This is a QRS complex. This is a T wave. Then there is a pause. Then there is a P wave. Is that right?
Yes, sir. Sir, what you said previously that it cannot be first degree because of?
It cannot be first degree.
Yeah, you
In
said
first
something.
degree, you can see that every P wave is followed by its QRS complex. Is that right?
Okay.
Every P wave is followed by its QRS complex. Now,
Mm-hmm.
see in this diagram,